please. Thank you very much. I think after Dr. Makka's talk, this talk again is all about advance, and we're going to be talking about the glucocentric approach in an era where people have been talking about the cardio-renal outcome studies. And this advanced study was actually done by Sardia, and it's a contracted lecture for me. And then I would like to thank RSSDI, Banshi and his group, Dr. Makkar, and all the others who have been a part of RSSDI and Sardia for having asked me to actually talk about the lessons that we have learned from advanced trial. In fact, from 2008 onwards, we have been learning a lot of things about what exactly the glycoside XR has actually done. Now, the first question that comes to our mind at the present day is, does glucocentric approach provide benefits in a cardio-renal outcome trials? Let's look at what exactly Advant has told us over the years. In fact, way back in 1997 itself, UKPDS clearly told us that if you go for a tight glycemic control, you can reduce the risk of microvascular complications. And what we saw in the UKPDS was a clear evidence of a 16% risk reduction in MI. But people were not happy with the 16% risk reduction with an MI. So this glucocentric approach then was criticized as it showed lesser than expected benefits concerning a cardiovascular outcome, because people were expecting much more. And at that time, our understanding of the actual role of glucose control was not very clearly known. And then we were not very clear about the multi-pronged treatment that diabetes really requires in order to reduce the cardio-renal benefits. But let's see what happened after that. So Advance was actually designed to look at both microvascular and macrovascular complications. And it was designed to see if a HbA1c can be pushed to 6.5 or less, will there be a benefit? And this was regardless of the initial blood glucose concentration. So the target of HbA1c was much lower than what we saw in UKPDS trials. Now, this is the patient population in the advanced trial. Important to remember, there's a huge number of patients. There were 11,140 patients. Mean age was 55. They were diagnosed after the age of 30 with a mean duration of diabetes of 8 years and a HbA1c of 7.5. And you look at the other parameters, the history of major macrovascular complications, the risk factors were present in 1/3 of the patients. Microvascular complications were present in 1/10 of the patient. And other major risk factors, especially vascular disease and microalbuminuria, was present in 28% of the patient right at the beginning of the trial itself. Now, this is just a comparison of the patient population that we saw in Advance versus Accord and VADT, because whenever we talk of Advance, invariably Accord and VADT also comes into the picture. There was a definite difference as far as the HbA1c was concerned in the Accord trial. It was 8.3. Remember, Advance was 7.5. And the mean duration of diabetes was about 10 years. In Advance, the mean duration of diabetes was about 8 years. So just to recapture, I have moved the slide back. So there was a definite difference there. Now coming to VADT, HbA1c was 9.4 and the mean duration of diabetes was 12 years. Now these are very, very important points to remember, that if you start late, the legacy effect, the bad legacy effect would have already settled. It's like you have taken your car to a very bad road and your car is damaged. You can't bring it back onto good roads and try to see whether the car will actually automatically become normal. This is the lesson that we learned actually after the Accord trial. But let's come back to our glucocentric approach. These were the differences between Advanced, Accord and the VADT. Now, what we saw in advance was something tremendous. And we all know that glycoside extended release was used, and the target HbA1c was 6.5, irrespective of the patient's baseline characteristics. That is what was done in advance. And we did see the reduction of HbA1c to 6.5 in the patients who took part in this trial. And this was the intensive arm of the advanced trial. And this reduction of HbA1c was seen across different BMIs, across different age groups, and across different durations of diabetes. So it did not matter what the BMI was, it did not matter what the age was, did not matter what the duration of diabetes was. The group or the arm which was targeted to get an HbA1c of 6.5, the intensive arm were able to get to that level of 6.5. Now, what happened after that? So there was a 10% reduction in combined, that is both micro and macrovascular complication. So we were able to see this over 5 years itself. Both micro and macrovascular reduction happened in the intensive control arm compared to the standard arm. Now you go back and visit ACCORD and VADT. You will realize in ACCORD, when they targeted an HbA1c of 6, there was an increased mortality. In VADT, there were no significant effects at all. Of course, the drugs used were completely different. And ACCORD study had to be stopped because it increased the mortality. Now, if you go back and look at these 3 trials, there were low rates of hypoglycemia in the intensive treatment arm of the advanced trial. And in ACCORD, the hypoglycemia was about 16%, VADT was about 21.2%, and in advance, it was 2.7%. Now, there's a very, very clear message here. Okay, the clear message is, even if you go for intensive control, the intensive arm that received glycoside XR experienced very few hypoglycemia in advance. Was this the reason for the huge difference that we saw? Well, we don't know. That was the speculation that we had then. Probably the biggest advantage that the patients in the advanced trial saw was very, very low rate of hypoglycemia, which is equivalent to what we see in some of the DPP-4 trials today. So the publication very clearly mentioned that a strategy of intensive glucose control involving glycoside XR-based regime that lowered the HbA1c to 6.5 yielded a 10% relative risk reduction in the combined outcomes of major macro and microvascular complications. Now look at the weight gain. Huge difference between ACCORD, VADT and advance. And in advance, the weight gain in spite of intensive control, targeting HbA1c to 6.5, the weight gain was only 0.1. Because there is a myth that if you go for intensive control and try to bring HbA1c down below 7, there is a good chance that you may actually put on weight. And now advance is clearly telling us that it did not happen in the advance trial. So there were a number of papers after this looking into the weight changes and the predictors. Many people said that, okay, we have to look at why advance did not show the reduction, why advance did not show the weight gain. In fact, one can read these papers at a later time, but what came out is the patient characteristic associated with weight change were actually the age, ethnicity, smoking, and HbA1c. And the main treatment strategies predicting weight gain were the use of insulin and thiazolidines. So advance did not use thiazolidines. We know about that. So the weight gain was not seen in the advanced trial. Now, what surprised everybody in the advanced trial was the reduction in the risk of EASD to an extent of 65%. And if you look at the numbers needed to treat to prevent one EASD is surprisingly low for macroalbuminuria at 41. Albuminuria, whether micro or macro, is 152. Overall is about 410. So the renal benefits that we saw in advance has not been shown with any other sulfonyl urea. And this has never been shown by a DPP-4 so far. This was a trial which went in with a glucocentric approach, which showed a combined 10% reduction. And they looked at the renal benefits. It was a clear 65% with no weight gain and no hypoglycemia. And this data is there. And people have looked into this data from all corners, trying to see what exactly is this drug actually doing. And regression to normal from albuminuria, especially from macro to normal, was seen in 20%. So I asked the same question. Now, if you have to use a sulfonylurea, here is a sulfonylurea which has shown fantastic reduction in HbA1c and reduction in both micro, macro, and most importantly, the renal benefits that we have seen with this sulfonylurea is not seen with other sulfonylurea so far, and definitely not seen with any DPP-4s. So the criticism or the myth that a sulfonylurea causes weight gain and hypo has been clearly busted with the data that we have in advanced trial. And that is what the publications have also clearly told us, that the data suggests that intensive glucose control may be an important strategy to curb the growing number of individuals receiving dialysis as a result of diabetic nephropathy around the world. And 20% reduction that we saw in advance is something highly praiseworthy. Today is a time when SGLT2s have shown us very clearly the cardio-renal benefits. DPP-4s have not shown that kind of a benefits. And will the guidelines over a period of change, because only fear we had with sulfonylureas was the weight gain and hypoglycemia. That has clearly been now busted with the data that we have from advance. And look at the renal legacy. After the trial ended, the patients were followed up for a period of 10 years to see what happens in the group which had intensive control earlier. In fact, the renal legacy continued and there was a reduction of 46% in EASD after 10 years. I'm sorry, ESRD after 10 years. And these benefits were greater in patients with preserved kidney function. There was, of course, a change in patients who did not have CKD and they were in CKD 1 and 2. But those who did not have CKD and who had preserved renal function showed a much better thing. That means trial ends, 10 years later, people's HbA1c has changed. Some of the medications would have changed, but still the renal legacy continued in the patients who participated in the advanced trial. So the publications that followed this clearly gave a message that the risk-benefit profile of intensive glucose control in patients with type 2 diabetes and impaired kidney function appears similar to that observed in those with preserved kidney functions. And of course, all this happened without any evidence or an increased risk of cardiovascular events or death. That's an important thing. Now look at the cardiac events also. Before that, we'll go across some of the points about the eGFR levels in the intensive treatment advance. Now, during the follow-up, the mean HbA1c level in the intensive glucose control was significantly lower than the standard glucose control in eGFR arms. But irrespective of the HbA1c, irrespective of eGFR, the HbA1c showed a good change. Now, when it comes to the cardiovascular benefits across eGFR levels, irrespective of the eGFR, there was benefit in the intensive arm. Irrespective of the eGFR, there was a reduction in major macro and microvascular complications. Irrespective of eGFR, there was benefit as far as the CV safety was concerned. Now, they also looked at ASCVD risk of the patients. It was divided as risk equal to or less than 20%, maybe 20 to 40%, and a risk with 40% and above. And across ASCVD risk, of course, the risk score engines were used to calculate this ASCVD risk in these patients, but across the ASCVD risk, there were macrovascular benefits and there were microvascular benefits in the advanced trial. So the final say was the therapeutic strategy and a regimen of intensive glucose control with glycoside extended release is equally beneficial for improving CV outcomes, irrespective of the existing ASCVD risk in patients with type 2 diabetes. So it started off as a trial to see about macrovascular complications when you intensively treat somebody to get a HbA1c of 6.5, and it started in 2008. It did show a combined microvascular complications, both micro and macrovascular benefits to an extent of 10%. 2012, it was very clear that it is weight neutral, there was no weight gain. And 2013, we were able to find out a fantastic reduction in the renal parameters. And we saw the renal legacy benefits in 2016. And over to 2020, we are looking at the benefits across the cardio-renal continuum. So glucocentric approach still has a role. Now, in summary, these are some of the points that we have discussed on that. So glucocentric approach is still a very important approach to prevent macrovascular complications. Never take it out of your mind. And advance with used glycoside XR clearly achieved a target HbA1c of 6.5 with very minimal hypoglycemia and weight gain, and vascular benefits seen in advance is irrespective of ASCVD or renal status of the patient. So these are the important take-home messages. And today, of course, is an era of SGLT2 and GLP-1 for CV risk reduction. But a few points that we should remember is, it is not the glucocentric approach that these drugs are using. The mechanisms are still not clear and established. And the benefits that we see from SGLT2 and GLP is unrelated to glucose lowering, as it occurs very early. That's what we have seen in the trials. And the CV benefits occur too early to effect of the weight reduction. So the future is probably going to rethink about this advance and probably think, why don't we actually add a glycoside extended release to metformin and an SGLT2 drugs? Now, how do we compare a sulfonylurea like glycoside XR and a DPP4 today? Just take a second and look at these points which I have put down. Glycoside XR regime has shown vascular benefits. DPP4 has done nothing so far. Weight neutral, no hypo, reduces sugar to some extent. The sulfonylurea like glycoside XR has better glycemic efficacy compared to DPP4. And myths about weight gain has already been busted. Yes, a slight increase in hypoglycemia is seen in patients taking sulfonylurea. It's not a side effect, it's the result of a better efficacy. Or I can say a very poor education on part of a physician who has not taught the patient what to do in case of hypoglycemia. Or it can be an error on part of the patient. So hypo, I don't think should be a side effect, because when you give insulin, you know you're going to get hypo. So when you're using sulfonylurea, it is the patient education that's important. At this point of time, sulfonylureas have overwhelming evidence to move up the ladder as a second add-on to metformin or a third add-on to met plus an SGLT2 combination. I really don't see a DPP4 dominating. The only advantage of a DPP4 here is, of course, no hypoglycemia, no weight gain. Apart from that, I don't think DPP4 can score over sulfonylureas anymore. Considering that the worldwide growing number of patients with diabetes, especially in India with 73 million, as caregivers, I think we must follow dialectical thinking and choose a synthesis approach where glycemic control is as important as control of cardiovascular risk factors and should remain the target to be achieved. We know macrovascular complication is a multi-pronged treatment. You need to use much more than just glucocentric. You need ASARB, you need statins, probably a drug like SGLT2 or a GLP-1. It is a multi-pronged treatment. So today for diabetes, what we have to practice is both the glucocentric and cardiocentric approaches are necessary for a disease as resilient as diabetes mellitus. Thank you very much for your patient hearing. With that, I will stop sharing the screen. Thank you so very much.